ICA debate. I'm not going to read out the full wording because it takes too long. But we're really pleased to have you all here with us this morning for what we hope is going to be a really lively debate around a really topical issue, I think, which is whether or not clinical academic roles actually create opportunities to address inequity in health and social care. My name's Suzanne Bench. I'm the co-lead of this scheme, along with my colleague, Professor Ben Thomas. And this scheme is particularly important one, I believe, because it's for healthcare professionals outside of medicine within the London region who have completed their doctorate at various different time points in the past and are now looking towards a post-doctoral clinical academic career. And these schemes are transition schemes, providing some support, some peer support, some guidance, some mentorship, and some opportunity to really think about what the career should look like going forward, and to build their applications for their postdoctoral fellowships for many of them. So that's all I want to say at the moment. We've got an hour for the debate, and we've got a couple of our colleagues here who are going to be co-chairing the debate, and that's Dr. Andrew Watson and Dr. Nick Byrne. And so I'm going to hand over to them, who will introduce what's going to happen a little bit more, and also introduce you to the rest of the participants of the debate. So over to you, Andrew and Nick.
Okay, thank you very much. Hopefully you can see that. Can you see my slide?
Yeah.
With the title. So hello everybody, a very warm welcome to the debate today. So we're here discussing, do clinical academic roles create opportunities to address inequity in health and social care? And as Suzanne mentioned, it's part of the LSBU NHS England postdoctoral bridging scheme group, bit of a mouthful. So we're hoping it will be a really stimulating debate this morning. So as mentioned, my name's Andrew Watson. I'm a clinical psychologist and I work in psychological service for psychosis at South London and Maudsley NHS Trust. And I'll, along with Nick, be chairing today's debate. As mentioned, the topic is going to be on whether or not clinical academic roles create opportunities to address inequity in health and social care. And we have a fantastic panel of speakers today debating on this motion. Two will be debating for the motion and two against. And I'm going to give you a little bit of information about the panel we have today. First of all, those for the motion, we have Dr. Melanie Dolby, who is, Mel is a clinical academic research lead for pharmacy at King's College NHS Foundation Trust. And her specialist area is as a clinical pharmacist in a haemato-oncology. She's the co-chair for the research subcommittee for the British Oncology Pharmacy Association. And along with her on the same side, if you like, is going to be Dr. Lucy Coombs. And Lucy is the lead nurse for the paediatric palliative and symptom care team at the Royal Marsden Hospital. And she's extensive clinical research experience in the field. She's also a member of the guideline development group for the first end-of-life care for children NICE guidance, and has been a registered children's nurse for 24 years, working in paediatric palliative care for 16 years. And then against the motion, so arguing that clinical academic roles don't create opportunities to address inequity, is going to be Dr. Sarah Stapleton. And Sarah is a clinical academic nurse researcher at the Royal Marsden, working in the applied health science team on research programs focusing on loving with and beyond cancer. Her specialist research interest is cancer-related cognitive impairment. And then last but not least, we have Dr. Jackie Wallum. Jackie is a clinical academic physiotherapist at UCL, University College London Hospitals NHS Trust, I should say, in London. Jackie works with multidisciplinary teams involved in the management of complex pain across specialties, and she's an honorary research fellow at the University of Oxford. So that's your kind of background for today's debate. And the structure is going to be as follows. So everybody is going to have 6 minutes to present their case, either for or against the motion. And after that, we'll open the floor to you all for questions. So there should be a chat box you can put questions in, and you don't need to wait till the end to do that. You can do that during the debate. But it won't be until the end of the debate that we open the questions up and ask the speakers directly some of the questions that you've asked. I believe if somebody else asks a question, you can also do a kind of thumbs up on it to upvote the question and make it one that we'll prioritise, particularly if it's popular. And then we're going to have a poll, both at the start, at the end, to see which way you're voting on the motion. The motion being clinical academic roles create opportunities to address inequity in health and social care. And then we'll see if your views change or don't change over the course of the debate. So Danny, I think we can do that now, and then we'll hand over to the speakers. Thank you.
Danny, can you just give people some instructions if you don't mind?
Yep. So in the chat, there is a QR code or a link. You can use either, and you can click or scan that and then answer the poll question. I'm sharing screen. You should be able to see the answers. Is that correct? Yes, I can see people are voting. Are you able to see the results?
We can see the results, which, but they're not. The results aren't in yet, but we can see
the results aren't in yet.
We don't want to see the results at this point, Danny.
No,
we only want to see them at the end.
Yeah, that's fine. I can see them. Good. It's a strange one poll everywhere. Sometimes it does show the results, other times it doesn't, and we don't want it to just yet. I can see quite a few of you have voted, though. That's good.
Great. And once that's closed, we're going to alternate the speakers. So we have Mel, who's going to be going for the motion first, and then we're going to have Sarah against the motion, Lucy for, and then Jackie against. So we're alternating views.
Brilliant. Good. Yeah, I'm seeing most people have voted. That's looking good. Okay.
Okay, are you ready for me to begin?
Yeah, I think we're ready to go. So I'll stop sharing now.
Right, so thank you, Andrew, for the introduction. So I'm going to start by discussing a couple of policies, but then I'll move on to give some examples to convince you that clinical academics do create opportunities to address inequity in health and social care. So the paper you can see here on the left is titled Equity and Excellence, Liberating the NHS. So this was written in 2010. So it indicates, so I quote, "Research is vital in providing the new knowledge needed to improve health outcomes and reduce inequalities." It goes on then to say that research is even more important when resources are under pressure. It identifies new ways to preventing, diagnosing and treating disease. It is essential if we're going to increase the quality and productivity of the NHS and to support growth in the economy. A thriving life sciences industry is critical to the ability of the NHS to deliver world-class health outcomes. So NHS England defines healthcare inequalities as unfair and avoidable differences in health across the population and between different groups in society. So the NHS long-term plan, which is the policy on your right, so this details a very systematic approach to reducing health inequalities and addressing unwarranted variation in care. So this plan, however, does not mention the role of clinical academics in terms of addressing inequity in health and social care. But it was written over 5 years ago, so it was published in 2019, and things have changed since then. So it's worth noting that both these papers do actually flick between the wording of equity and equality. And at the time when they were both written, clinical academics were perhaps not as common as they are now, particularly non-medical clinical academics. But what they do highlight is that research is recognised as an important factor, particularly with regard to reducing inequity. They just don't state who it is that's going to be undertaking this research. So I believe that clinical academics have the skills and abilities to be the ones to do this. So this slide shows some examples of different funding bodies that recognise the importance research has on improving inequity and inequalities. And so there's multiple examples of targeted funding calls that specifically request this type of research. So we've got ones here from the NIHR, the UKMR, the UKRI, and from our very own King's College London. So all of these funding bodies provide the opportunity for clinical academics to undertake research which could be around improving inequity in health and social care. So I'm going to move on now. So I've got a couple of slides where I talk through 3 examples of clinical academics who are actively partaking and leading research in regards to reducing inequity. So Kate Alton. So Kate is a clinical academic programme lead at Great Ormond Street Hospital. So she is a nurse clinically, and she is chief investigator of an NIHR study that is looking to identify the barriers and facilitators to children and young people with learning disabilities and their families in terms of receiving equal access to high quality hospital care. My second example is Teresa Clark. So Teresa is a physiotherapist, and she has done some research into the factors affecting the inclusion of people with severe brain injury and reduced decisional capacity into randomized controlled trials. So this example is Dr. Sabrina Bajwa. So Sabrina is a clinical senior lecturer at King's College London and is a consultant in palliative medicine. So she is also the Equality, Diversity and Inclusion Executive Lead at the Cicely Saunders Institute of Palliative Care. She's a passionate egalitarian and really drives forward equality, diversity and inclusion in all aspects of her clinical and her academic work. So examples of her work as a clinical academic who is not only creating opportunities, but is actively addressing inequity in health and social care, include her published studies on insights of palliative care services, caring for people from ethnic minority groups during COVID-19. And then she's currently a principal investigator for an NIHR funded study looking at equitable bereavement care for all. These are 3 really great examples of clinical academics who have created opportunities to be able to take forward their research to reduce inequities. So just got a few final statements for you to think about. So clinical academic roles provide time and freedom to undertake robust research, which can be used to address inequities in health and social care. Clinical academics often are translational researchers, so therefore their research will directly have an impact on health and social care. And then lastly, clinical academics are in a really unique position in that they can actually spot inequities occurring in clinical practice. Thank you.
Can you see my slides?
We can, yeah.
Not as full screen, that's it.
Yeah, okay. So despite the encouraging work taking place by major funding bodies such as the NIHR, as Mel's just stated, there remains huge disparities for both patients and public from underserved groups and researchers from ethnic minorities and underrepresented backgrounds. Diversity inclusive initiatives can feel like rhetoric unless underlying issues are tackled at a cultural, organisational and individual level. And there is much evidence on the disparities that remain for researchers and the populations they serve. So to demonstrate the issue with lack of opportunity or impact of these equality initiatives, we can look towards evidence of underrepresentation of certain groups of researchers, particularly in leadership or at a senior level. So in English academia, people from Black and Asian and ethnic minorities account for 10.3% of staff. And at a senior and professorial level, that's just 0.4% in relation to the 18.3% of the general population. Baroness Amos, the first Black woman to lead a college at Oxford University, reflects on her experience at senior university meetings, stating that if there were 100 attendees, 90 would be white men, and just 2 women from Black and ethnic minority backgrounds. There's also evidence of underrepresentation when it comes to funding awards and disparities in funding. Researchers from Black and ethnic minorities often have lower success rates in securing funding, and when they do, their grant sizes are smaller than those of their white colleagues. And this in turn can, of course, impact the opportunities to conduct research with broader impact and influence health inequalities. Shockingly, it seems that bias in access to publishing is also evident, with researchers from ethnic minorities having less publication and citation rates, fewer editorial board positions, and longer review times in what's explained in the literature as systemic racism. Pay disparities for researchers exist, particularly at senior positions, further demonstrating inequities for researchers themselves. So a good example of a positive initiative to influence inequity is the Athena Swan Charter Mark framework that sets out good practices to advance gender equality. It's been running for over 15 years. And despite some positive outcomes of increases of women in mid-management roles, there is still no evidence that membership of Athena Swan has made any difference to the proportion of women in the top quartile of pay, or indeed the overall gender pay gap. Is this an example of a top-down initiative making lots of noise but having no real impact? So putting together the evidence of underrepresentation for researchers makes the point that unless there is diverse, adequate representation, and this is of race, different backgrounds, professional disciplines, at a senior level, making decisions and influencing direction of research funding and research, there cannot be true opportunity to address the inequities that exist in the population. There's also underrepresentation of participants in research studies and clinical trials. So the way that trials are designed means that these population studies often does not reflect the diversity of the population. Relative to the prevalence in the general population, people from Black and ethnic minority backgrounds, women, older people, and people with disabilities are all underrepresented in clinical research. This creates a data gap that threatens generalizability of findings. This potentially creates huge problems for certainty of efficacy in certain groups, and possibly a difficulty in accessing interventions once they come into practice. So trial design issues such as unnecessary exclusion criteria for cognitive and mental health, unnecessary exclusion criteria, for example, excluding patients that don't speak English, people with limited literacy, cognitive and mental health issues, and poor reporting in trial data of these certain characteristics can perpetuate the problem. This creates the risk that we're just not understanding the effects of interventions in the right context. Despite long-term efforts to try and address this, a good example to show that we're not studying the right parts of the population is the recent COVID vaccine trials. This illustrates clearly failure to study the relevant groups. Looking at US data, 21% of COVID deaths came from the Black community, but only 3.1% were included in the vaccine trials, with other minority groups being underrepresented. Other issues aside of trial design and exclusion criteria add to the problem of researching the right people, lack of access for certain groups in the community, awareness, practical issues for some parts of the community, such as childcare issues, transportation and financial issues, can really restrict people's ability and also willingness to participate. So putting together the issues around underrepresentation makes the point that we simply can't have opportunities to address inequalities if we're not studying the right parts of the population in a context. And adding to that, the evidence presented before around the lack of diversity in senior investigator and leadership roles suggests that this is unlikely to change without a push of inclusivity at a senior level. So we need to look at why this underrepresentation happens, in particular hindering the opportunities being created. So sadly, there is systemic and structural bias, discrimination bias in recruitment, promotion and funding decision that disadvantage all underrepresented groups. The ways in which workplace policies are written are often inflexible, making work-life balance decisions difficult for certain sections of the community. Certainly, it's more difficult to be a researcher that has to pay to go to a conference or to present their work if you're financially disadvantaged. We also sadly continue to have evidence of institutional racism. Recent work by Dupree suggests that academic institutions that are historically exclusive continue to be so, with examples of racial ignorance, racial stereotyping. She states in the paper that racism permeates every area of society and academia has not put itself above that. And moving across to clinical areas, we hear some examples of hostile workplace cultures for clinical academics, particularly of underrepresented backgrounds, examples of microaggressions, exclusion from the boys' club, lack of understanding of the value of research and therefore support from clinical managers is commonplace, particularly for researchers from nursing and allied healthcare professional backgrounds. And there's also evidence of lack of mentorship and role models for underrepresented groups that adds to this cycle of inequity. So putting all that together, we cannot have true opportunities that make meaningful impact without addressing these structural and organisational issues.
Thank you, Sarah. Over to Lucy.
Sorry, I'm struggling with, there's always one, struggling with my slides. Can you see those, Andrew?
Yeah, we can see them, yeah.
Perfect. Okay, so we're moving back now to the argument for the case that clinical academic roles create opportunities to address inequity in health and social care. So I'm going to argue the case for this from 4 different points. So I'm going to argue that clinical academic roles are uniquely positioned to address inequities in health and social care. Clinical academics have a dual capacity, which Mel touched upon in her speech just now. So by working clinically, clinical academics can identify gaps in their clinical work and then address these in their research role. They can also promote interdisciplinary collaborations, both within their clinical role and within their research role as well. And thirdly, clinical academics are uniquely positioned in that they're working clinically, they're working with students, they're working with maybe junior healthcare practitioners, but they're also often positioned within an academic institution and are teaching our future healthcare workers, so are well positioned to drive systemic change through education and training. And finally, as clinical academics, we are well positioned to influence policy, both again from our clinical work and through our research work. So I'm just going to during the rest of my slides, sort of talk about these 4 points in a little bit more detail with some examples. So firstly, thinking about dual capacity. So clinical academics are well positioned to identify gaps in the evidence through their day-to-day clinical work and address them through their research. And I've got 2 different examples here. So the first one by Sarah Mitchell. So research conducted by clinical academics has highlighted disparities in access to palliative care services for those from diverse backgrounds. Sarah Mitchell, who is a GP and also the National Clinical Director for Palliative and End-of-Life Care for NHS England, has worked in partnership with patient and public involvement members to understand some of these barriers to inclusive patient and public involvement within palliative care, both in research and in clinical work. And she's created resources to support equitable and diverse and inclusive patient and public involvement in this sector, and has collated a framework to go alongside this. In my second example, it was identified that cervical screening uptake is lower in some minority ethnic groups. Imogen Rees, who is a GP trainee, or she was when she did this research, conducted a systematic review to identify interventions that could improve the uptake of cervical screening. So as you can see, I know Sarah mentioned that certain groups are underrepresented in research studies. So here you can see that there's actually some real sort of on the ground work going on to try and improve this representation, particularly with some of the patient and public involvement work that Sarah Mitchell is doing. So moving on to my second point around promotion of interdisciplinary collaboration. So clinical academic roles encourage collaboration across disciplines, and this includes, medicine, nursing, public health, social care, etc. And it's really crucial for addressing complex health inequities, usually because we're not just working in a biological model of healthcare anymore. A lot of these inequities have psychosocial underlay to them as well. So this sort of interdisciplinary collaboration is really, really important. This can lead to comprehensive strategies to address the social determinants of health, which are often at the root of health inequity. And the example I've given here, so this Health Foundation publication, so for this, clinical academics partnered with policy officers to outline a framework to understand potential approaches to address social factors that can shape health. So education and training of future healthcare providers. So if we can incorporate issues of equity into sort of undergraduate curricula and postgraduate curricula, we can sensitise future healthcare professionals to the importance of addressing health disparities. So as clinical academics, we know what the health disparities are from our clinical work, and we're often teaching in universities to undergraduates and postgraduates, so we can sort of highlight these disparities as part of our role. Healthcare providers who receive training and cultural competence, as evidence shows that healthcare providers that have received this training are more likely to provide equitable care to a diverse patient population. So there's evidence underpinning this. And this impact extends beyond individual practitioners and can sort of disseminate out into the broader healthcare system as principles of equity are carried into multi-professional practice. And the example I've given here, so you is a nurse practitioner, and they identified that LGBTQ+ individuals experience health disparities that adversely affect them. Their paper found that cultural competence training may improve patient-provider interactions by enhancing healthcare professionals' knowledge, skills, attitudes and behaviours. So finally, thinking about advocacy and policy influence. So again, as clinical academics, we're very well positioned to advocate and influence policy. We can use our expertise and research findings to inform this, and this can lead to systemic changes to promote health inequity. So in the example given here, this example is of Medicaid expansion within the US, where clinical academics advocated for policies that expanded access to healthcare services for underserved populations. Their dual role enabled them to provide compelling evidence-based arguments highlighting real-world impacts of health policy on vulnerable populations. So in conclusion, I hope I've convinced you that clinical academic roles are instrumental in addressing health and social care inequities by developing targeted evidence-based practice, fostering interdisciplinary collaboration, education of our future healthcare workforce, and engaging in policy advocacy work. We're well equipped to tackle this complex and multifaceted nature of health disparity. Our work doesn't only improve care for underserved populations, but can also drive systemic change towards a more equitable healthcare system through policy change. Thank you.
Thank you, Lucy. And then we'll hand over to Jackie for the final point against.
Okay. Can everybody see my
We can see them, not full screen yet, but we can see them.
How about now?
Yeah, perfect.
Fantastic. So I am going to take the position and hopefully convince you all that perhaps clinical academic roles are not all that when it comes to thinking about inequity in health and social care. And I've come from a position of clarifying what we mean by health inequities. From the World Health Organization, they remind us that health inequities are systemic differences in health status or the distribution of health resources between different population groups arising from the social conditions in which people are born, grow, live, work, and age. And it's from this position that I argue that thinking about the wider systems of oppression that are at play in developing and maintaining health inequities, that we need to think a little bit more broadly about what intersectional properties maintain these systems of oppression, such as economic exploitation, queerphobia, sexism, ethno-nationalism, racism, and ableism. And we have started these conversations in my own field. So I'll start my argument for you by suggesting that systemically, research that develops clinical interventions has a form of methodological idolatry. By that I mean that most of the methods that we draw on and draw to are fixed within a biomedical paradigm, and non-medical AHPs, non-medical clinicians work with a variety of different methods that reflect the practice environment more, and that some of these methods are not valued as much within the evidence-based hierarchy, which continues to prioritize positivist methodologies such as clinical trials, which we all are familiar with. And I would argue that using these methods, we continue to establish damage-centered research narratives where we go out into these underrepresented communities and may perpetuate predatory or exploitative behavior because of asking questions that are based on this methodological prominence. And therefore, when we think about which paradigms are prioritized and whose knowledge is prioritized, I think that we are not really going to get to a point where we can start to realistically and sustainably address health inequities. We also see this in the lack of parity when we think about funding, research funding for clinicians or clinical academics who are not from a medical background or working within biomedical research strategies. My second point is that majority of us working clinically, particularly in the NHS, work within complexity. This is a piece of work that demonstrates that when we have people with a single healthcare condition, they're likely they're also experiencing a multitude of other conditions, which builds in complexity into our models of care. So if we're thinking about working with multiple health conditions, unfortunately, the single disease intervention models that really are successful in winning funding and being disseminated are never going to adequately account for the issues we have within health inequities. Also, having these single disease paradigms can lead to more competitive environments where we're all fighting for the same pot of money, rather than collaboration, for example, that fostered with team science-based approaches, where multiple teams come together and work on complex research questions together. At the moment, clinical academic structures for those of us not in medicine currently favors fellowships, which means that you're always making the case for hopefully working only within one of these particular disease groups. And so if we're thinking again systemically and about some of these oppressive forces, I argue that context matters. And we've already heard about the pressure to be successful. We have issues such as publication metrics, which I would argue are also publication politics, such as the narrative that your H index is a valid marker of scientificness, rather than perhaps thinking more broadly about some of the other methodological paradigms that we might wish to work in. We also have issues of fast science, where the pressure is on delivering multiple publications and this mantra of publish or perish, which is certainly the case for most of us working with this environment. And whilst we laud the funder intention to provide funding for us working in slightly different areas and to address health inequality as well as health equity, that is not borne out, I would argue, because the structures of peer review have not changed. We continue to have built-in bias within our systems, which means that even the most innovative projects that might make a difference on some of these more complex issues are not necessarily funded equitably. And finally, we have this issue of an implementation paradox, though it's argued that clinical academics would lead to translation of research insights into practice. Because the research insights come from relatively sanitized environments and clinical trials, they would almost always not reflect what happens in a practice environment where we tend to see complexity built up in multiple layers. And so for me, retaining people in clinical academic roles will continue to be a challenge if we do not fund them to do the work that really makes a difference in practice roles. And until there is parity in what we're thinking about epistemologies or ways of knowing and different types of methodologies that embrace other ways of knowing, which some of our communities might value, and which might reflect their experiences and priorities of accessing health and social care. And until we restructure the function of research and clinical academic roles within that, it's always going to be that these ambitions we're hearing about are only rhetorical ambitions and do not lead to actual structural change. And therefore, the work on acting on social determinants of health will continue to be a challenge and inequities will persist. Thank you.
Thank you, Jackie, and thank you to all our speakers for some really interesting presentations. I appreciate you sticking so well to time as well. It's grateful not to have to tell anybody to stop early. I believe we've got a few questions in the chat, so we'll have a bit of a Q&A. Nick, I apologise, I didn't give you a very good introduction at the start, so maybe you want to introduce yourself and then pass any questions out to the speakers.
Yes, no problem, no problem. So my name is Nick Byrne. I'm a clinical scientist. I specialise in medical physics and clinical engineering at Guy's and St Thomas's NHS Foundation Trust. My research interests are around anatomical modelling and particularly the way in which we understand the heart for children with congenital defects. But that all pales in comparison, really, doesn't it, to the sort of the complexity of the challenge that's been debated here today. So I think now it's my job really to try and marshal some of the questions. We've had some come in through the chat, so I think probably it's best for me to start there. So there hasn't been a tremendous amount of voting for questions. I'm going to ignore the thumbs up and thumbs down if that's okay, and I'm just going to go through in order. So Danny asked firstly about the use of particular terms that might be outdated or have racist implications from the past, and whether we'll be able to make progress until those terms are updated, I suppose. I guess anyone from the panel can answer, but I suppose but perhaps I can frame the question through to the against side to say, is it some of these wider contextual issues that have limited clinical academic roles rather than the roles themselves? What do you think?
I suppose that's some of us, but I would agree with your posit, because unless we look at the context in which people live their lives, including clinical academics themselves, it's always going to be a challenge in the framings. So like Danny said, you get categories that are already existing, and we then align our questionnaires, our patient experience measures all within existing categories, which for the most part have been shown to be inadequate and in some places really, really damaging. So I think that unless we start to look at oppressive systems, and including changing some of this language, it was really heartening to hear colleagues talking about underserved populations, which is moving away from hard to reach, for example. So I do think that there's a bigger task here and a bigger ask in terms of shifting the contribution of clinical academic roles.
Thank you. And anybody else from the panel with a comment on Danny's question? Mel, off you go, please.
I was just going to add that, yes, it's likely there are lots of historical racist demographic terms that are a little outdated and perhaps we shouldn't be using them anymore. And I suppose going back to what Lucy said in her presentation on the foresight was that clinical academics are essential in educating the future researchers going forward, and this could be something that they could perhaps educate on, particularly if dealing with inequalities in health and social care is part of their specialist area. They are going to be the key ones to help make that change.
Can I just jump in and ask something off the back of your question? Is anyone's specialist area health inequity from a clinical academic side? No, okay, just interesting. Oh, there you go, Danny. I suppose you can speak. So okay, that's interesting. What's your but is your profession, like, is your clinical profession? What's your clinical background?
No, that's just what I was going to say. The difference is, this is a clinical academic. I'm a university academic. There is a difference, and I think in terms of the observations, and the thing I loved about this debate was, it's for people in leadership positions, it's for people who are in position. That's where the challenge really is. Whereas from the academic side, mine is more about the research integrity and authenticity, anti-racism, inclusion. So when we see there are a problem with leaders and research leaders, it's down to the leaders who are in position to distribute that power. So a lot of my work is in decolonizing research practices and empowering people from minoritized groups as the leaders on projects, because just because they might not be seen as the specialist or the leader, they can still meaningfully lead and contribute. And it's been working really well the last year or so. Love it. It's taught me so much. It's taught me a lot. It really has. So that's where I love this debate, both sides, because I think both sides have so much merit. I'm not a sit on the fence guy, but I'm not going to say what my opinion is at this stage.
Thanks, Danny. Very, very good to hear that it's going so well. Sorry, Lucy, I'm going to ask you to come in now.
So I had one more point from Danny's question. I guess as clinical academics, we're probably quite well positioned to take up journal sort of editorial posts, reviewing articles, etc. And actually there's a role there for making sure the right terminology and language is used in publications, so making sure that we're not being racist and these historical sort of demographic terms are being used from that perspective as well. So in our role as reviewers and maybe journal editors, I would say.
Thank you. Right, I need to keep going with these questions, otherwise people won't get their questions asked. So next up, I've got Suzanne. So Suzanne has a question around, I suppose, the aspects of inequity within the clinical academic field itself, in addition to the impact that clinical academics might have on health and care of our population. So Suzanne's question is, what can we do practically to increase the representation of clinical academics from outside the traditional demographic groups? I started with the against side before, so we'll ask this to the for side. I suppose the for side, do you think that there's the potential for these roles to make a difference? So how are you going to change this? This is for you.
I think there's a big role for mentorship and mentoring people to become clinical academics on the ground. So maybe those junior nurses that from underrepresented backgrounds, for instance, and encouraging them to maybe take part in a research study you're doing, do some data collection with you, helping to do an audit, even just giving them a taste for what it would be like. And I think that's the beauty of being on the ground in clinical practice, is encouraging people even to play a small role and showing them what they could do.
And it doesn't just have to be the foresight. If anyone else wants to add, whilst you're thinking, oh, Jackie, go on.
I think it's a really important question because on one side, what we tend to hear in some of our own work has demonstrated that gatekeepers in the NHS are really, really challenging. So even though the opportunities are put forth, for example, to go forward and do academic projects or professional development, if there are biases within the system and there are gatekeepers who prevent those opportunities from being accessed, that could be a potential barrier. And I think work really needs to be looking at our middle managers, our clinical managers, as we've heard from before. On the other side, I think focusing on things like mentorship, whilst important, can be really, really difficult, because it is a little bit of a deficit-focused narrative. So there's the suggestion that it's because you don't know that we need to bring you up to this kind of level. I think there's space for that, alongside perhaps a reaching out and going, I'm going to have to reach around some of these systemic barriers and blocks and target my interventions to groups that kind of acknowledge the strength-based approach and say, I see you do this really well in your work, but that really does need to come from organizational levels, from system leadership, because otherwise individuals would really struggle to make their way through these kind of barriers, as we all know, because we've all been through the system.
Thank you. And I saw that Edwin was like agreeing, well, putting thumbs up whilst you were speaking, and Edwin's question actually sort of addresses, I think, some of those points that actually both of you raised in your response to the first question, which is around having role models who are representative of the different groups within the population, really. And you just both of you have spoken about the importance of that and the ambition to have those role models and mentors. Jackie, you said it was difficult for individuals to make that change without the system adjusting. So I suppose, again, either side, what actual adjustments do you think the system might have to make in order for those mentors and those role models to be representative of the population? Big question.
I mean, if I might keep commenting, I think it's always going to be the difficult version. We've heard the stats from Sarah. There's not that many leaders, let alone clinical academic leaders, in positions of authority that reflect the wider population across different protected characteristics. So therefore, mentorship was always going to be the most limited space. But there is that question of allyship that Danny spoke about, and Lucy has also raised that everybody can kind of do this work and make it an imperative to lift up people who have shown an interest. So I think maybe thinking about outside the box. I really like Danny's, idea of let's bring our communities involved in this picture, let them be the leaders in some way, because perhaps then you come up with slightly different ways of thinking, because those of us in it, we're so used to doing things the way they've always been done.
Thanks. Okay, let's have Mel's turn next.
I was just going to say that I think it's important as clinical leaders that we support each other. So we're not just one person individually fighting the system on our own. So if clinical academics can sort of group together to help tackle these issues and mentor others who are wanting to get involved and perhaps target specific demographic groups that are perhaps underrepresented, that would definitely be obviously a positive move. And I mean, this scheme, for example, has brought us together, which means we're now debating this particular topic.
Thanks, Mel. Well made. Sarah.
Yeah, I think, as I said, it does require a multi-faceted approach, and we see structural policy changes and organisational commitments to improve things. But I guess at an individual level, everyone needs to take responsibility as well. And whilst preparing for this, I did speak to some people that I work with, and it's a lot of these awful stories about being excluded from publications, about doing a lot of work and getting the data taken so someone else can write it up. That's still happening. It's hidden, but it must be seen by people. So I guess it's about being brave and calling it out when it's seen, which is very difficult to do because of power dynamics. But I think we all have a responsibility to do that.
Thank you. Okay, I'm aware that we've only really got 9 minutes left. I know that Suzanne, you want some time at the end, but can I ask one last question, or do you think now is the time to move forward?
No, please carry on. I need a minute.
It's okay, great, that's fine. So actually, it's sort of a follow on and it's a follow-on from your previous question. We've done a lot of talking, I suppose, around a lot of introspection as clinical academics about our own role, right? And I suppose the question that Suzanne asks here, in almost a Russian doll fashion, is, do our own biases as clinical academics, how strong an influence are they on, I suppose, the clinical academic role in general to drive change and to reduce health inequity? So the question is around the individual biases of clinical academics and how influential are they in the ability of the role to address health inequity. Has anyone got a view? Mel?
So I think they are important and could play a role, but I think as clinical academics and senior members of staff, obviously very experienced in what we do, it is our responsibility that we're aware of what those biases are that we have, and whether they're conscious or unconscious biases, and that actually going forward in trying to tackle issues such as this, we should be aware of them. And I think that awareness will then reduce any potential negative impacts.
Thank you. And anybody else? Whilst you're thinking about that question, Simone has just entered into the chat. So she's asking whether there is funding for underrepresented groups to develop as clinical academics. Anyone, not just the panel, anyone on the meeting? It's always good to share opportunities when they come up. Anyone on the call want to put their hand up and advertise any funding opportunities for underrepresented groups?
I think, Nick, so there is this rhetoric. I think this is the important thing, is the funders have a commitment to it. So it's on all the websites. It's very much, the Wellcome Trust, for example, has made a very focused bid for academics from minoritized and underrepresented groups, but it's not for clinical academics. And so for that perspective, one needs to have an academic role and be in an academic institution. Most recently, there's been an NIHR call from underrepresented professions, not necessarily talking about that, but I think there's a lack of ambition and a lack of courage in specifically saying, let's put a call out for different methodologies, for doing things differently. Because if we have a slightly different epistemology and a different knowledge practice and a different knowledge base, surely we need to draw on different ways of thinking and different ways of doing. And I'm not seeing that in the clinical academic world, albeit I've only been in it for a little while. But I think that if you're able to attach yourself to an established group, for example, who are already doing big work, it's a lot easier than if you come up with your own little slightly spicy questions. It's just going to be a much more of a struggle. So I think the funders have a role to play in changing the infrastructure of peer reviewers, what a journal editor's doing, and being a little bit more focused in their ambition.
Thanks. So to some extent, clinical academics ourselves, we are an underrepresented group, right? That's there we are. And I know my line manager likes to talk about professional ED&I as another sort of dimension. So it's a nice kind of shorthand that he uses, which won't cover everything that you've spoken about. It's far too rich, right? But it's something that he's spoken about with me before, so it's quite interesting. Andrew.
I just wanted to speak about being an underrepresented group as clinical academics, but also that, there are barriers for minoritized groups in academia, but also in clinical professions. So, for example, not to say I'm on either side, but for psychologists, there's a huge lack of diversity in clinical psychology. So it's not just about the barriers to getting into academia or clinical academia, but there's also barriers for some groups into getting into the clinical roles in the first place. So I suppose it's this multifaceted barrier, which then leaves you with quite a small pool of people who are clinical academics, and probably an even smaller pool of people who are clinical academics from minoritized backgrounds.
Thanks, Andrew. I think we're probably approaching the end of our time. So I'll just say thank you to everyone who's asked and answered questions, because it's made my life much, much easier. I can see that Danny has put the QR code back up for people to vote again. But I think after that, I'll hand back to you, I suppose, Andrew and or Suzanne, however you want to close off the session is great.
Andrew, do you want to take the poll results and then hand over to me? Exciting, eh? Which way will it go?
Just waiting a couple more. Another minute. Give it another minute to vote. We've got quite a few who have voted.
I think we'll have to close because it's a minute too.
Yep. Give me a minute and I'll put that together now. Okay. And should now be able to share the results.
Andrew, do you want to comment? Oh, it's gone.
Gone?
It's gone.
Yep.
Oh.
Is it there again now?
Yes, we can see it now.
Good.
Okay, shall I pick up it then? So interestingly, so we had 73% in favour at the start of the debate. So the for team, you started off very strongly, but the against team, I have to say, have come back fighting. So whilst there's still an overwhelming majority for yes, and I think really like to pick up the point that Jo Cole made in the chat, that actually she voted yes because of the keyword being opportunities, that we might not be there yet, but actually it's about what the opportunity is. So maybe that's what influenced the overall vote of for. So thank you very much to both sides of the debate, and also to the fantastic chairing by Andrew and Nick as well. I just wanted to close by not only saying thank you to them, but also thanking Danny for his technical support, without which this wouldn't run quite so smoothly. So thank you to you too, Danny, and thank you to you all for your questions and your engagement. I don't know if any of you on the call are aspiring clinical academics, whether you have your doctorates, whether you're looking to move forward with your careers, but I did just want to flag one event that is coming up, which is our webinar on these schemes. And these schemes are running both from a pre-doctoral and a postdoctoral and the internship. And I've just popped in the chat a link to a webinar coming up on the 19th of July, which is going to give an overview of all of those three schemes, how to apply, and opportunity for Q&A. So please do have a look at that, share it with your colleagues, and we hope to see you there. And look out for the next debate, which will be in the next cohort, of which you might be part of if you apply to do the postdoctoral scheme. So many thanks again. I hope you all have a very happy Friday and enjoy the weekend, whether or not you're working. And we hope to see you in the future. Thank you all.